Well, I'd like to thank our faculty and our now-to-be panelists for wonderful reflections on dealing with COVID and the connection with co-production principles and methods. We've heard from Anna, a person living with a serious health problem in England. We've heard from Amit, leading the response in a state in Australia. We've heard from Christian, organizing a citizen dialogue-based response in a canton in Switzerland, and then from Eyal, Sheba Medical Centers, and its very creative response to this crisis. So we'd like to invite questions or comments from you all, and are there microphones that people, yes, can come down to? So please take a little bit of time and come forward with your questions or comments. We'd love to hear them. And as you think about your questions, let me first give you a question. So, number one lesson learned from your experience in the pandemic. If you had to say, well, I learned a lot of things, but the number one lesson that I learned was, how would you respond to that?
That's difficult. I think as a patient, it's probably to be more confident, actually, to push back and explain the reasons why your voice is really important and that it is heard, even in a crisis. Yeah.
Thanks, Anna. Amit?
Yeah, for us, I think, firstly, I'll have to acknowledge that, I've only presented one piece of what fitted into the co-production, because the whole pandemic, and I think for me personally, the lesson has been when there is a disaster, it's not just health that is impacted. It is, like yesterday, I think around the global disasters presentation, it is beyond health. And the way we respond to it cannot just be health. It's about being open, partnering beyond health, and the response needs to be a societal response and can't be a single paternalistic health response, especially in the level of disaster. But also from my personal experience leading the community response in the state, it's been more about that engagement piece. When we actually, the movement from being paternalistic and telling you need to do this, to a model where we give that power to the patient to navigate, give the pressure, but then noting that there are pockets who may be at disadvantage by setting those principles and making tailored models for those groups as well, so yeah.
Just say a few more words about beyond health. When you said that, what comes to mind first?
So, during each of those phases, when we went into lockdown, we worked very closely with the police department and the legals, and the contact tracing required a lot of community support as well. But as we moved to different stages, we needed to work closely with multicultural organizations. One thing we realized was there were no products to do surveys in different languages and be able to predict a patient's language and send it, even though on our health records we knew which patient prefers to talk in what language, but to deliver those surveys in a way that they can engage better with them. So engaging with patient literacy organizations, engaging with disability organizations, social services. So it was about that holistic care. We were finding that places, the spread was higher, not because people didn't care about their health, but because they had to leave their home, otherwise they'd go hungry. So you've got to plan those things all around the patient, and I think, I'd say the team, New South Wales Health Team and all the other organizations work really well in that space to collaborate. Or you could see all the walls fall down between organizations because we all buddied together to develop those solutions for the people.
Thank you. Thank you. Christian.
So my lesson, number one, a bit as you said also, it's really about keeping the connection. Keeping the connection where, with, for example, community services. So where we didn't do well, for example, in nursing homes, community care, we didn't have enough connection. So we didn't have enough communication, we didn't know what was going on, we didn't have partners, and then it didn't go well. So keeping the connection.
Well, you know, follow up on my presentation, I think what I've learned is that whenever you include patients from the very, very initial process of redesigning care, of quality improvement, it always provides added value. It's not something that we do you know, instinctively. It's not an instinct for us to go to patients and involve them in these decision makings from the first initial steps. But every time that we've tried it, we came up with a much better solution. So leading innovation at Chiba and going through the innovation efforts were still on, which is obviously still ongoing. Right now, what we've learned from COVID is to have patients being included in many of these innovations really from the start. And we're seeing a lot of benefit through doing this. So even without calling it co-production, because that's not a term that everybody uses, but having those stakeholders at the table from day one is obviously critical also for innovation. So, you know, from our perspective, COVID was a great lesson in that regard.
Thank you. Questions? Many steps down. Thank you. A little physical fitness.
Thank you. Peter Carter, Australia. Thank you for your presentations. Two speakers said directly and others implied that there was almost a reflex reaction when this disaster hit to return to paternalistic medicine. Is that inevitable, or are there strategies we can put in place to protect co-production when disasters strike?
I'm happy to start off. Yeah. We did discuss about this yesterday, and this, as an emergency physician background, I've always said that the best way to address chaos is by having structure, and that's same thing with military organizations, is that when you go into war, you can't just shoot off bullets, you have to be very targeted. But a lot of our guidelines, a lot of our processes and procedure manuals fall back on the best procedures we know how to do. To make sure that co-production is not lost every time we are hit by a chaos or a disaster, what we really need to do from now on is make co-production a day-to-day activity in health. So it becomes so embedded in general healthcare practice that if we do have our disaster manuals, they are embedded in this. And I think there was a great example yesterday, one of the speakers from one of the questions from Fiji, and it was a comment on one of the things where the IPC person said her discussion with the health to highlight that we want to make a decision to have family members in the treatment facilities for COVID, and they then designed everything around it. So there needs to be a bit of political courage, but there also needs to be that pre-planning from now on so that we make sure that when we do have another pandemic or any other disaster, we, as clinicians and patients and organizations, just know what to do even when there is a crisis.
Christian.
Well, thank you. Great question. Well, I indeed think it is a reflex. It's kind of a default default mode of operation. So as with other default modes of operation, so if it is the duck or the rabbit, you can organize to avoid this. So crisis team organization does make plans. I mean, crisis teams makes plans for pandemics, for example. And there's always a communication chapter in preparation for pandemics. So it's always kind of the first thing, communication is important. But the way it is presented is that it is one-way communication mainly. So it doesn't include dialogue. So to put that, for example, in the preparation would be an important step to avoid this. So we didn't, in our crisis team, we had a communicator in the crisis team, obviously. She would prepare messages. So it was more the radio mode, but she did not have any information back. She would screen social media a bit, but that was very heterogeneous, obviously. So preparation.
Thank you. Other questions?
Yep. May I?
Dr. Braithwaite.
Jeffrey Braithwaite, ISQua, and the Australian Institute of Health Innovation. Thank you for this fantastic session. When we're thinking about sea change, when we're trying to make the tectonic plates change in a health system, I often think to myself, are we doing a push strategy or is it a pull strategy? Or when might it change to a pull strategy? That is to say, we're kind of trying to be architects to create, in some respects, some of the speakers were, co-production. But co-production is going to work best when it's led by patients. And it's a pull strategy that the patients are really in the lead. When might we get the tipping point when that's the case? When might we get at the case when we don't have a session like this, but that the patients are perhaps in the entire lead of the ISQua conference and the health system?
Would like to, Christian?
Thanks, Jeffrey. That's a nice question. Well, I don't know when, obviously, but I think that your observation is totally correct. It is very much, in my example, we were sitting there and thinking, well, we should do this for, right? And we were trying to get to with. And that did work wobbly well, I would say. So, so what I see is, I think there was actually a lot of pull. There was a lot of pull, and it was even the case that we kind of suffocated that pull. So it was a question of power also, power asymmetry, and power was obviously very centralized during these waves. So what I can see in my system now is that citizens do get organized. So they don't want this to happen again, and it's not only the pandemic, obviously, but they do get organized. So there's a recent example of citizens who arranged quite a big meeting and invited lots of people and say, and what came out of that is that, well, actually we have to get organized. We have to institutionalize our role in the system. So we need the capacity to do this. We need to have enough citizens who can join a crisis team, for example. So.
Sorry,
Anna.
I was just going to say, it's slightly controversial, but I don't want to be in the lead. I want to be part of the system, and I want to be an equal part of the system. If I was in the lead, then I think that would be taking away the power of the clinician, and the clinician is essential. I said in my presentation, I wouldn't be here without my clinicians. And I think when I first started working in the NHS, I was given an induction. One of the presentations was about the health system and the parts of the health system. Yeah. And we got to the end of it, and patient hadn't appeared anywhere in that. And that was an NHS presentation of what a health system looks like. That's not acceptable. But I think there's a middle ground.
One of the thoughts I had with Jeffrey's questions was if each of you were to go home and write the next version of a pandemic response playbook, how might you use a pull strategy and the engagement of different players, including patients and families, in the new response plan for the pandemic. So you don't have to make it up when it happens. We've planned on how to best get the right combination of push and pull.
I wanted to make a comment on Jeffrey's comment there, and I think just to add to what Anna said, if the patients were totally in lead, then I don't think it would be co-production either. Because I do agree there needs to be this balance of a push and pull about what we need and what we can provide, and a balance of the two. And to your question there, I think we really need to start changing the way we design most of our healthcare and make it daily practice, where every instance of planning should involve a patient's voice around understanding the need. And it's not just, I mean, I think we see that lots of time everywhere else, and not just in service delivery. It's just, you know, I've got an app, great. What did you build it for? I thought it'd be useful. But there's never been any feedback on what the need or what the... So I think to understand the need, we really have to partner very well, and it has to go across the whole spectrum, from planning to implementation. It has to be an equal journey, a partnership.
Jean, I do want to just add to that, because it's a critical issue, and Jeffrey's question is of course fundamental to much of what we do at ISQua. I think that you know, regardless of pandemics, let's put pandemics for a second on the side, because 99% of what we deal with is not pandemic related. Hopefully we'll get back to it very soon. How do we get to that point of co-production in healthcare, period, regardless of the question of pandemics? I think it's an evolution that we are in the midst of this happening.
Was that an evolution or revolution?
Evolution.
Evolution.
Because you know, if your organization will not be able to do this, your organization in one way or another will not survive. Will not survive as a leading organization, will be pulled to the side in terms of your place in the healthcare sector. You know, we still are asking questions. We had a discussion at Chiba Medical Center whether or not to allow patients to see their pathology reports the second that they come out. We know that there's an issue with that question, right? Because you can see it on the screen. Technology is easy. But you know, if they see they have cancer and nobody is there to relay that to them in the proper words, how would they see this? So it's somewhat of a paternalistic question in many ways. And you know, when it was my turn around the table to say my thoughts, my reaction was, it's not going to be up to us. The patients are going to have to say, with the minuses and pluses of, you know, deciding this way or that way in terms of revealing those information. So it's not really up to us to make those decisions. The decisions will be made by the patients. You might call them consumers of healthcare services. And I think the organizations and countries that will not move ahead in this process will be left behind. So moving forward 10, 15 years into the future, I think this would become a norm in terms of co-production and patient-centered care. The focus would be on outcomes that matter to patients, and we will have to adapt the whole system so that the patients are in the center of what we're doing. Again, if we don't do this through an evolutionary process, we will cease to be.
That, in terms of time, has to be the last word. Anna has a little surprise. Would you come up and orchestrate this final surprise? And thank you for our panelists and faculty.
Okay, this is a test now, and most of the people with the letter are our board members, so we'll see how they get on. I'm going to ask you actually to get up and come to the front and turn around and show these letters to the audience, and see if you can arrange yourself in the right order.
You'll have to do this in an orderly way.
Yeah, you got to think through, bit of teamwork here. Don't know. I'll have to think about the. You've got to work it out. Work it out. It's a test. I heard that, Jeffrey. Have you got it? And if I can invite my colleague Isabella Castro up here to read out what that says. Isabella is the other honorary advisor to the board on person-centred care, for those who can't see it. No, come up here. Come and say.
Thank you, Anna. What I can read, not just with my eyes, but also with my heart, is better is together.
Thank you very much.